The radial nerve is the other terminal branch of the posterior cord, and it extends all the way to the hand. Along its course, the radial nerve supplies all extensor compartment muscles of the arm and forearm, plus two others, brachioradialis and supinator. The radial nerve also provides sensory innervation to skin on the dorsal surface of the arm, forearm, and hand. The radial nerve begins its distal journey by traveling posteriorly around the body of the humerus to lie within the radial groove. The radial nerve comes to lie briefly within the flexor compartment of the arm as it travels across the elbow joint anterior to the lateral epicondyle of the humerus. Just distal to the elbow joint, the radial nerve divides into superficial and deep branches. The superficial branch is purely cutaneous and travels distally along the radius to reach the hand, where it provides sensory innervation to the skin over the dorsum of the thumb and radial half of the hand. The deep branch is motor and enters the posterior compartment of the forearm by piercing the supinator muscle. Within the posterior compartment of the forearm, the radial nerve is known as the posterior interosseous nerve, or PIN. Wrist drop, resulting from loss of innervation to the extensor muscles in the forearm, is the signal characteristic of radial nerve injury anywhere along its course. Injuries proximal to the triceps innervation will also include loss of elbow extension. In addition to these motor signs, radial nerve injuries are also characterized by loss of sensation or paresthesia over the dorsum of the thumb and lateral aspect of the hand. The radial nerve is especially susceptible to injury in the arm during fracture of the shaft of the humerus, or as a result of compression from, for example, the use of crutches, draping the arm over a chair back, or sleeping with the companion's head resting on the arm, hence the term honeymooner's palsy. The ulnar nerve is a terminal branch of the medial cord. The ulnar nerve does not innervate any structures in the arm, but travels distally to enter the forearm by crossing the elbow joint immediately posterior to the medial epicondyle of the humerus. Once in the forearm, the ulnar nerve is paralleled by the ulnar artery, as they both continue distally along the medial aspect of the forearm towards the hand. Along the way, the ulnar nerve innervates 1 1/2 forearm muscles, the flexor carpi ulnaris muscle, and the ulnar 1/2 of the flexor digitorum profundus muscle. The ulnar nerve provides cutaneous innervation to the medial 1/3 of the hand, and motor innervation to the hypothenar muscles, and all of the other intrinsic hand muscles, except for the thenar muscles and the first two lumbrical muscles, which are innervated by the median nerve. The ulnar nerve is commonly injured by entrapment as it passes behind the medial epicondyle of the humerus. This results in tardy ulnar palsy, which includes paresthesia over the ring and little fingers, and loss of fine motor control of the digits. More severe injury to the ulnar nerve during fracture of the medial epicondyle of the humerus, or during trauma to the wrist, will produce paralysis of the abductors and adductors of the digits, and commonly results in claw hand, in which the little fingers and ring fingers are hyperextended at the metacarpophalangeal joint and flexed at the interphalangeal joints due to loss of lumbrical and interosseous muscle function in the extensor expansion of these digits. Median nerve injury is most commonly associated with carpal tunnel syndrome, in which the nerve is entrapped or inflamed as it enters the wrist under cover of the transverse carpal ligament. The most common symptoms are paresthesia and pain along the thumb, index, and middle fingers. Severe carpal tunnel syndrome may result in atrophy of the thenar muscles and subsequent reduction of thumb movements.